This Week in Virology, the podcast about viruses, the kind that make you sick. From the 16th International Nidovirus Symposium, this is TWiV, This Week in Virology, episode 1009. Oohs and ahs, please. Recorded on May 16th, 2023. How many TV shows have 1,000 episodes? Come on, right? That's really good for a nerdy virology podcast. At least I think it's cool. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Today we are recording in Montreux, Switzerland, where 400 or so nidovirologists have come together to discuss their craft. Nidoviruses are positive strand RNA viruses that include coronaviruses and many other viruses, and they're all the topic of this meeting. By the way, we did a TWiV at the last in-person nidovirus meeting in June 2017. It was in Kansas City. I have two guests from the meeting today I'm really happy to speak with. On my left, from the World Health Organization, where she is the head of the Emerging Diseases and Zoonoses Unit, also the technical lead of the COVID-19 response, Maria von Kerkhove. Welcome to TWiV.
Thanks for having me.
Yeah. And on my right, she is director of the World Health Organization Collaborating Center for Reference and Research on Influenza, also professor at the Doherty Institute in Melbourne, Australia, Kanta Subbarao. Welcome to TWiV.
Thank you very much.
I noticed I said Melbourne correctly, right? Because I visited there and they taught me how to say it. It wasn't that hard. All right, so let's start with a little bit of your histories. By the way, Maria, someone at this meeting, and I'm not going to say who it was, asked me to ask you if you knew what your name meant.
Of the churchyard, yes.
Churchyard?
Of the churchyard in Flemish. It's my married name. My maiden name is Di Giuseppe.
Oh, Di Giuseppe, very good.
Yeah.
Actually, someone said it meant cemetery.
Cemetery, of the churchyard, in the cemetery of the church, in the church.
I think that's
I probably got that wrong, and I failed the first question of the podcast. Excellent.
I think churchyard is a nice way to put it, though, right? Okay, so tell us your training that led you to your current gig. And I know you're from New York State, which is pretty cool.
Yeah. I am from New York State, upstate New York, right in the center of the state, New Hartford, New York. My background is in science and math, and I always had a love for it. I didn't really understand much of it, and it really blew my mind when I went to college, where I was studying medicine. I didn't finish all of the pre-med courses, but I loved the science field. And during my summers at Cornell University, and we both went to Cornell, I studied ethnobotany and how plants were used medicinally. And during my summers, I was lucky enough to travel with Eloy Rodriguez and some other students, where we worked with medicine men and medicine women and looked at the plants that were used by animals and by indigenous peoples and how they cured disease. So I was really quite fascinated with disease itself and how, some people got sick and others didn't. And I think that was my start of love for epidemiology, which I didn't know existed when I was an undergrad. I took one course in epidemiology at Cornell, and I really didn't like it. I really did not enjoy it at all. But when I went to Stanford, studied epidemiology and really loved the science of it, really loved the detective work. I saw it very much as like detective work. It doesn't have the same policing tone as it does in 2023, but I really loved investigating and understanding. And I got involved, when I finished my master's at Stanford, I wanted to get out of academia and pay back some student loans. Growing up in the States, you have tons of student loans, and I wanted to work, and I got a job in New York for a company called Exponent, where there was an engineering firm, and my boss studied electric and magnetic fields, believe it or not. And what I learned from that was studying the weight of the evidence in a field that I knew little about. And I gained a deeper appreciation for looking at all of the types of science, all of the types of studies that were conducted, and really understanding what the weight of the evidence meant. And I carry that with me to this day. When I did my PhD at the London School of Hygiene and Tropical Medicine, I chose a school that worked in international health, really worked in international health, and had most of their staff doing research overseas and in a collaborative nature. And from there, I was so fortunate to work on H5N1, avian influenza in Cambodia, with Institut Pasteur Cambodia and Surrender Vong. And everything I learned about One Health was from his staff in the field. Before One Health was fashionable, before I think it was even called One Health, well known, called One Health, and I loved field investigation. So there were very few human cases of H5N1 at the time, and I spent all of 2 years in markets, live animal markets, chasing down middlemen, carrying birds on the back of their motorbikes on the side of the road to interview them, to figure out where the birds came from, where the birds were going, so that we could advise the ministries on how to best use limited human resources, financial resources for surveillance. And I just absolutely loved it. I loved the people, I loved everything about it. And it just, forgive the pun, but it's infectious, this field that we work in. And I absolutely love this field of work. I don't love it every day. I don't, but I love the work every day, but the days have been more difficult in the last couple of years. But I get a lot of questions of how did you get that job of being the COVID lead? I didn't get that job. I didn't aim to get that job. I didn't apply for that job. And I certainly didn't apply to be the quote unquote face of COVID. That was never part of the terms of reference. It was just another thing that I had the privilege to do at WHO. So I've always wanted to work at WHO, tried to get in as early as I possibly could. And it's been an incredible experience so far. Challenging, privileged, but I love it.
So did you go there right after the Cambodia
No,
experience?
I went, so during, when I finished my PhD, it was March, April 2009. And I had moved over to Imperial College. I was working with Azragani. She was one of my PhD supervisors. And one of the roles, Imperial, at the MRC Center for Outbreak Analysis and Modeling, they were looking for someone to be the liaison between WHO and Imperial College. I worked in a modeling group. I'm not a mathematical modeler, but I worked to be that link between public health policy and analytics and modeling. And essentially what I was doing was working on developing projects on how that skill set, that type of work could support WHO programs to be more efficient, to make best use of resources. And the 2009 flu pandemic started. So I went April 27th, and I stayed essentially for 10 months straight, going back and forth. My poor husband, I left him again. First time going to Cambodia, next time going to Geneva. And I just got involved in working with WHO, and I coordinated the mathematical modeling network during the 2009 flu pandemic. And in between, after that, I worked on yellow fever and meningitis and Ebola and MERS. And in 2015, I left London and moved to Paris to head up their outbreak investigation task force, which was part of their Center for Global Health. It was essentially a mini GORN across the network. And then I joined WHO in 2017 as the MERS coronavirus focal point. And at that point had been working with WHO, since 2009. So lots of different field missions with them, working on the development of guidance. And my interest was always in how does this data, what's the so what factor? How does that data actually translate into action and helping people? So a lot of different types of backgrounds, but led me, I guess, to.
So you never applied for this job, but you grew into it with this work that you've just described, right?
Yes, and when you have an event with SARS-CoV-2, which of course we didn't know was SARS-CoV-2 at the time, as the focal point for MERS coronavirus, I became the technical lead and health operations and technical lead according to our emergency response framework when we set up our incident management team.
Okay. We'll come back and talk more about that, but Kanta, I'd like to hear, I guess you know each other, right?
We do.
Really well?
Very well.
Do you talk like on a daily basis, maybe?
Daily, no. But regularly.
Okay, Kanta, tell us your history.
Okay, so I'm a pediatrician by training, pediatric ID physician with an MPH in epidemiology, but many, many years ago, while I was a fellow in pediatric infectious diseases, I spent a lot of time in a respiratory virus lab and started working on RSV, and absolutely loved being in the lab. So I tried a few times to balance doing a bit of medicine and lab and gave up on the medicine. So I don't practice medicine anymore, but I think it hasn't changed the way I think about questions and the fact that I work in translational medicine or translational science. So I worked a little bit on RSV, and then I went to Bob Chanuk's lab, the Laboratory of Infectious Diseases at NIH, and spent 5 years as a postdoc. But they told me when I applied that I couldn't work on RSV, that position was committed. Turns out to be Jim Crow. Ryan wanted me to work on flu. So I went sort of kicking and screaming a little bit because I was overwhelmed by the idea of catching up with 50 years of literature and all the subtypes and everything. But it was the best decision. I absolutely loved it. And it changed my career. So I worked on flu. I consider myself an influenza virologist. And after a postdoc there, I did spend 5 years at the CDC as head of the molecular genetics section of the flu branch. And our lab characterized the first H5 virus from Hong Kong in '97. But I went back to the NIH, and I spent the next 14 years running a lab in the intramural program in LID, the same lab that I had originally trained in, where I set up a pandemic influenza vaccine development program. But 3 months after I got there, SARS hit. And I had worked in a BSL-3 with H5 avian influenza, and so I put my hand up and said that I would like to work on this. And in fact, I came to the 2003 meeting in the Netherlands, the coronavirus meeting, to learn about coronaviruses, and Mark Dennison took me around and introduced me to people. And I have to say that this is the best field. You're so welcoming, so friendly, so open. It's incredible. But anyway, I went back to flu. Dabbled a little bit in MERS, but I did work for about 5 years on SARS, animal models primarily. Have a lot of great collaborations, but then went back to influenza. And 6 years ago, I moved to Australia, to Melbourne, to the Peter Doherty Institute, where, as you said, I'm the director of one of the 5 WHO collaborating centers for influenza. When SARS coronavirus 2 hit, Australia closed their borders, so we had no influenza for 2 years. So it freed me up, and my research lab pivoted completely to SARS-CoV-2. And it's been very exciting, very invigorating to get back involved with it. So here I am.
All right. Well, here's something about it. So Maria, let's go back to you. I think for our listeners, they all have heard of the World Health Organization, WHO. They probably don't know what it is and what it does. So could you give us a little brief summary of that?
I can try. It's interesting that you asked that question, because I think before this pandemic, I think a lot of people maybe never heard of WHO or didn't really know much about it. I think that's changing in the last few years. So the World Health Organization is part of the United Nations with a mandate on health. And to keep the world safe, protect the vulnerable. And we're organized, we're about 8,000 staff, a little over 8,000 staff globally. We have a headquarters based in Geneva, Switzerland. We have 6 regional offices across the world. And we have about 150 country offices. And we are organized around different health aspects, whether it's communicable diseases, non-communicable diseases, emergencies, humanitarian crises. And we, a lot of people, sometimes when I am in the States, I explain it as, a lot of people know what USCDC is. And I explain this is not the perfect analogy. And so we're having an intimate conversation with about 400 people watching us at the moment, but don't hold this against me. But I like to describe it a little bit like USCDC. We try to do what USCDC does in every country. And so we are the secretariat of 194 member states. And our member states give us the mandate of what to do, what to work on through resolutions and through different mandates. I work in our health emergencies program. in the Department of Epidemic and Pandemic Prevention and Preparedness, and I lead our work on emerging diseases and zoonoses. And so a small, little, tiny pocket of what WHO does is to ideally prevent pandemics, which is a very lofty goal. But we work with governments, we work with ministries of health, we work across the quadripartite with our animal sector collaborators, we work with national influenza centers, WHO collaborating centers, we work with academics, we work with partners, we work with CSOs, we work with people everywhere to prevent infections from happening, and when they do happen, to prevent severe disease and death through a variety of different aspects. And one of the things I think our superpower is to convene the world's expertise. All of you in this room contribute to the work of WHO in one way or another, whether it's through a lab and a collaborating center and a referral laboratory, or whether it's through research studies that we've seen many presented here at this conference, sharing that information to turn that knowledge, that data, into evidence-based guidance. And we work with our countries through our country offices to implement that with ministries of health and with other ministries. So a lot of different things we do. But our budget is less than one New York City hospital. Our staff size is less than one New York City hospital. So we're stretched. We work on everything from infectious diseases to cancer to tuberculosis to climate change across the gamut. And it's really an admirable place to be, I think.
So I used to consult for WHO years ago, and I was always told we have no laboratories, but we collect information, right? Well,
that's a funny thing you say, because a lot of time in this pandemic, people thought we had labs out back, that we were, I kept getting the question, did China send you the virus? And I said, well, we don't take viruses. We don't have a lab out back. We don't make the test kits. We don't. No, what we do is we work with labs around the world, and with people and researchers and scientists around the world. But no, we don't have labs. We have collaborating centers, national influenza centers, reference labs across a variety of different types of pathogens.
So you collect information from the scientists who generate it, right? Would that be a fair way to say it?
From scientists, from public health professionals, from communities, a variety of different sources of information. It's not just the papers that are published. We're trying to do more participatory type science. We're trying to collect data on infodemic management, on trust, because you can have the best guidance, but you can't implement it if you have no trust in your community. So it's taking lots of different information. And as you know, science changes. And so what we do has to constantly evolve and change and adapt. And that's quite, I think people paid attention to that in the last 3.5 years, because science changes, guidance changes, communication, and how you communicate that changes.
That's actually one of the issues people have with science, is that it changes. They don't want it to change.
Yeah.
And when we change because of the data have changed, they think we're being evasive.
Yes.
And they don't trust us for that reason. So it's a matter of them understanding how this process works.
And I think that's hard. Science is a process.
Yeah.
People have said to me, when is the science going to be done? And that's just not how it works. But it does pose a very difficult communication challenge, because as you change, they say, well, why? So you have to be able to explain that. You have to explain the uncertainty. And in my role in communicating, it's been, what do we know? What don't we know? And what are we doing to find out? That last part is almost the most important one, because in the beginning you have so little information, and to be able to work with a global community of scientists to be able to say, we're working on that, and it's going to take us a couple of weeks or a couple of months, that's really an important metric to communicate, to say we're on it. We don't have that answer yet, but we're working on it.
I'm curious about the process that you use to, say, make public health recommendations. Is it all people in-house who are looking at the data, or do you get scientists from outside to make committees to do that?
No, this is not WHO sitting around a table developing guidance. It's a good question, because I think a lot of people think we sit around, or that I wrote guidance during the pandemic. I did not. We work with a global community, and we set up guideline development groups. We do systematic literature reviews when we can, when there's data to actually allow to do that. We use a grade process, which actually evaluates each piece of evidence in each paper that comes out, because not all science is good science. Not all papers are high quality, and there's limitations that need to be taken into consideration. So there's a guideline development group that we work with across the spectrum, whether it's infection prevention and control or clinical management, looking at a specific therapeutic, to evaluate the evidence, to formulate a recommendation or a good practice statement, and then there's a process by which it's reviewed. So not only is the recommendation reviewed, but the methods to come up with that recommendation are reviewed. The document itself goes through a clearance process, which is external and internal to WHO, and then it's published. We have interim guidance, which has a very short shelf life, which is meant to be 6 months to a year. And that's what we normally use during emergencies, because we don't, the data is changing so much that a recommendation has to be updated regularly. We have formal guidelines that have a longer shelf life. And we have other types of information products. But the second you publish something, it's almost already out of date. So once that's published, disseminated, used, we have a feedback mechanism. More data is involved, and then you do it again. So my role in the pandemic as health operations and technical lead was to work with the world's expertise to set up these expert groups and these guideline groups to develop the guidance, the evidence-based guidance, publish it, translate it, implement it, start again. And we have thousands of products that have been published, probably too many, to keep track of, but across the whole spectrum: EPI, transmission, IPC, clinical management, infodemic management, et cetera, et cetera.
So no one's obligated to listen to you, right? Not you, but WHO.
We don't have them. I mean, we issue the guidance, and we work with governments to set the policies. There's a big difference between guidance and policy, as I talked about the other day. But no, we don't have, a lot of people think we have these powers that we can go into any country, and a lot of this came up in the, in the discussion around the origins, and we don't have this parachuting power to go into any country and, the member states that we work with, and all countries that we work with have the sovereignty. We have to be invited in. And so we push to be invited in, and we request to be invited in. And I've been in many countries and done these outbreak investigations, but no one is forced to listen to us. But in many countries, not just low-income countries, what we issue in terms of guidance is what is used in hospitals. So a lot of people take it off the shelf and implement it as is. And so it's a really important responsibility.
So do you ever do some kind of a survey where you see how you're doing?
Oh, constantly.
Yeah.
Constantly. Because we're a learning organization. And so I think a lot of people like this sort of argumentative of you were wrong and you correct. We course correct all the time. All of us are doing that. Not just because science changes, but also because the situation and the context is changing. If you just look at the pandemic itself, the context in which the last 3.5 years has unfolded, there's so many challenges that countries face, that communities face. A stay-at-home order, which we never issued stay-at-home orders. Ours were stay at home if unwell and get a test and get clinical treatment. But if the policy is to stay at home, those people who don't have the opportunity to continue to work and make a salary can't feed their families. It's not as simple as that. In this pandemic, this virus affected every single household on the planet. And a lot of people suffered because of those stay-at-home orders. So you have to, weigh that up. So we do surveys all the time through our regions, through our countries, whether it's with regards to how the guidance was implemented, whether they're trust surveys, or whether they're surveys that we do with governments to say, how ready are you? How was this helpful or not? Because it's this iterative process.
So what would you think a world without WHO would look like?
A world without WHO would have our member states set up another type of WHO. This organization exists to serve the world's population, and it's the only organization mandated to do that at a global level. If we didn't exist, it would be established. So whether we like it or not, we're here to stay. We're doing the best we can. But I really think the people that work there in particular, I'm very proud to be WHO.
Well, many countries have like CDCs, right? And I assume they would fill the void.
They do at a national level.
Right.
They do at national levels. And what we are looking at is from a global perspective. And so when you have something, if you even just look at vaccines, you look at the implementation of COVID-19 vaccines. In the beginning of this pandemic, we didn't know we would have a vaccine. let alone safe and effective vaccines, so effective at preventing severe disease and death. But the world, from a scientific point of view, collaborated beautifully. I mean, incredibly. But in terms of the use of those vaccines and the solidarity and, you know, the nationalism of using that was really quite strong. So you need a global organization that looks at this and also looks at the inequities that exist before any virus starts to circulate and address those inequities. Primary health coverage is one of the foundations of what WHO is focusing on, is not a catchphrase. You know, having earlier treatment, prevention. Health is a right. Health is a human right. It's not a luxury. It's an investment.
So at the outset of the pandemic, how long did you think it would take to develop vaccines?
We didn't know. What I did know is through the R&D blueprint work, there had been previous work on MERS coronaviruses and SARS coronaviruses, so the collaborations were set. Once we had the sequence, the groups hit the ground running. I didn't know. We didn't know.
Okay.
But a year is very quick.
It sure
but it
is.
didn't just start on January 1st. You know, it really started before that. So it was really a race to get that out, and not just to get it out, but to get it into the arms of those who are most at risk.
Sure. What did you think? How long it would take?
That's a good. So I had more confidence than some people did that we would have vaccines because, you know, as Maria said, the work on SARS and MERS had established the protective antigen, the fact that neutralizing antibody would actually protect from disease and death. But a year, that was really quick. And I think the mRNA technology is really what changed that, and the, you know, advances in technology in general.
I have a multiple choice question in my exam in my class, and one of the wrong answers is all vaccines take over 1 year to develop. And it's just because of COVID that's wrong now, right? Because before they did take over a year. So I wanted to ask both of you another common question. So in March of 2020, the Director General declared a pandemic, right? So do you guys have a definite, I'm wrong, okay.
You're wrong. Well, go ahead, no, ask your question.
I want to know if you have a definition of pandemic.
Oh my gosh. So actually on the 30th of January, the Director General declared a public health emergency of international concern. We don't declare pandemics in that sense. We described it as a pandemic. And the point of declaring a public health emergency is to do everything you can to prevent a pandemic from happening. Now, whether or not we were going to be able to prevent a pandemic from happening is highly debatable. And given SARS-CoV-2 and all that, probably wasn't possible. But the whole point of an alarm is to do it early and early enough. But he described it as a pandemic in March. Right. A definition of a pandemic. We're working on it. And it's a horrible answer because for flu pandemics, and Kanta can talk about this, in the past, for the 2009 pandemic, we had these phases. We don't have those phases anymore.
Right, I remember, yeah.
It may potentially be arguably easier to say once we've reached a point that we are in a pandemic. The harder question is when the pandemic is over. That's even more difficult. So we don't have a good one. I mean, pandemos, right? It's a pathogen, an immune naive population. It's circulating. There's a lot of discussion of whether there should be a severity point in there. We have TB, you know, tobacco pandemics and obesity pandemics. So what is an acute pandemic or an infectious disease versus? So there's a lot of discussion about this at the moment.
So what you're saying is you don't know the definition, but you know it when you see it.
Exactly.
Okay. Do you have a definition for a pandemic?
Well, the definition that I usually use, Maria touched on some of those factors, and I think it's very much a virologist's view of a pandemic. It's something we've used for influenza for years. I have slides on this. That a virus qualifies as a pandemic virus, usually influenza, but certainly coronaviruses too, if you have a novel virus that infects a population that is non-immune or susceptible, causes disease in that population, and then importantly spreads efficiently from person to person through sustained chains of community transmission. Again, as Maria said, after 2009, there was a lot of criticism about the declaration of the H1N1 pandemic because there was no feature of severity involved. And so that's something that has been being looked at for flu. But I think those features, those three features of a novel virus to which the population is non-immune and the virus causes disease in the population and spreads efficiently from person to person, I think are the key features. To me, the game changer with SARS coronavirus 2 were two features. One is the ability of the virus to spread from person to person efficiently, and in a frightening way for them to spread from asymptomatic or mildly symptomatic individuals. Those were two key differences from SARS-1. And that really makes a difference to control.
Okay, so disruption of people's lives is not part of the pandemic definition, you think?
No, I mean, the other factor that Kanta mentioned, in the efficient human-to-human transmission, for us, a lot of people were saying, well, but in how many countries, how many WHO regions does it have to reach before you reach that stage of calling it a pandemic? Certainly, I think the factor of disruption of people's lives, I think, has to do with the severity as well. I think no one had anticipated how impactful this invisible pathogen would disrupt people's lives. And the thing that's so striking to me and so upsetting to me is we've had estimated 20 million deaths. But how many people, if we look at excess mortality, didn't receive the vaccinations, childhood vaccinations, didn't receive the early cancer diagnosis, didn't receive the treatments that they needed to do because essential medical services were so disrupted. How many children out of school have developmental delay? How many children did not go back to school? A lot of young girls will never go back to school. Some of them were married and having children. And how many futures were altered? I think we're really only starting to deal with that, the mental health aspects of this. It's substantial. So I think we expect pandemics to not only transmit efficiently, all of those factors, transmit efficiently, cause disease. I think there's some debate around how severe does it have to be. In my mind, you don't have to have a severe disease to cause a pandemic, or to call it a pandemic, describe it as a pandemic. But certainly, if we had seen in the beginning of this pandemic severe disease in children, I think we would have had a very different response. Yeah. If we had seen a higher level of mortality in the beginning, and we did see a high level of mortality in the beginning, we would have had a different response. The question is, how do we use this experience now to make sure we do better the next time?
Is the pandemic over?
It's not. I'm sorry to say. I think from a technical point of view, this virus is circulating in every country on the planet. It's still causing severe disease. We're much better at managing it. The crisis phase is over. And so the lifting of the public health emergency of international concern is significant. It's a milestone. It's an accomplishment. But there's still more work to be done. I mean, we've had so many discussions about the virus itself and how it is changing. We've had Omicron for more than a year, but we don't have a predictability yet. We don't have a seasonality yet. We have a periodicity, one could argue, if you kind of look closely, but the virus is taking advantage of the situation. We don't have this all worked out yet. So we are in a pandemic. And with flu, and Kanta should comment about this, when did the 2009 H1N1 flu virus is still circulating. In 1918, it circulated until, 1957. So it's very difficult to say when it's over.
But you would say the 2009 pandemic is over, right?
Yeah. So, in fact, we actually don't want people to continue to call it the pandemic, virus. And there are parts of the world where the press still calls it swine flu pandemic. And we say, no, it's now the seasonal virus. So once it replaced the previously circulating H1N1 strain and became established and were circulating on a seasonal level, it becomes a seasonal influenza virus. So we do transition with flu.
Are we in an AIDS pandemic still?
Some would argue yes. Yeah.
Yeah, I would think so.
Yeah.
Now, we just heard a talk where norovirus was called a pandemic. What about that?
Well, see, you highlight the challenges of using these words, that are so common. And I think the public that's out there, we've had an incredible reaction during this pandemic to people craving reliable information. And there's a lot of very good information out there, but there's much more misinformation, disinformation out there. And these are hard concepts. Everybody wants a yes or no answer. And if I could answer every question with "it depends," they wouldn't actually ask me to do any interviews ever again. But it's hard. It's complicated.
Well, that's why I bring it up, because many people want to know, what is a pandemic? Is it over? When is it over? And so forth. And they don't often get the right answer. It's nuanced, as you know, and often mainstream media doesn't do well with nuance.
I think the media has been a really strong advocate during this pandemic. I mean, we've relied on journalists, science journalists, to get good information out. And it is hard and it is complicated. So we keep coming back and doing these press conferences and doing these live Q&As because we're at, there's more questions to be answered. And, we shouldn't see journalists and the media as adversaries. They've been very helpful. Not all journalists are good journalists, but not all scientists are good scientists. So I think we can argue one way or another. But I think the point is that we as scientists, and this is something I definitely wasn't prepared for during this pandemic, is we have to be decent communicators and good communicators. And I think we shouldn't be afraid to say when we don't know something and that we're working on getting it to get it out. But I was just not prepared for the snippets and the 2-second clips to like the clickbait kind of headlines, and just we're trying to do our best to get good information out.
I teach a virology course, so I need a definition of pandemic for it. You haven't given me one, that's fine.
I'll come back to you.
But I have a slide and I have my own definition. It may not be right and it may change from year to year, but I think it's important to at least give people some idea what you're talking about. Yeah. And by the way, people think that WHO declares pandemics, by the way.
I know.
I obviously did.
It's okay. No, it's okay. I think what it's not really trying to point out that the point is when you raise an alarm, you want to do it early enough so that countries take action, so you could potentially prevent the worst situation going forward, and that's very difficult to do.
So that's the key point, that you declare a public health emergency of international concern. To alert countries, you need to get ready. With it, get ready.
Yeah.
Right?
And many countries took it on. I mean, countries across Southeast Asia, in Asia that dealt with MERS, that dealt with SARS, specifically SARS, that dealt with avian influenza, knew immediately the threat. Activated systems right away. Even countries in Africa, that had very limited resources in certain space. I was with a colleague in China in February 2020, Chikwe from Nigeria CDC, and people were saying, Africa will not be able to handle this. He's like, hold on a second. We know how to do surveillance. We know how to do contact tracing. One could argue that many high-income countries did pretty poor on the contact tracing side in the beginning and on the surveillance aspects in the beginning. So I think those who took it seriously and did what they could and really warned the public and utilized systems fared much better in the beginning, much better in the beginning. And it's really just sort of a shame to see how this pandemic unfolded, particularly in the first year.
One of the things that's come up at this meeting already is vaccine inequity globally, and that must be something WHO would like to work on.
Absolutely.
How do you deal with that?
So part of it is a variety of different ways. Part of it is we're trying to ensure that technology transfer is occurring so that there are more people that can produce these vaccines, to have more production facilities around the world, not just in high-income countries, but in other countries around the world, to have agreements in place, that when vaccines are available, that they will be utilized based on need, on where everyone is around the world, not just in the high-income countries, and to get rid of this nationalism that occurred, a lot of different ways. And to get ahead of the game. We've seen the presentations here on the work of trying to have these pan-coronaviruses and looking at influenza viruses, because we can anticipate what the next one will be. But it's not just one answer. And COVAX tried to deal with this during the pandemic to make sure that there was some element of equity in that. We're not there yet. We're still not there yet. And a lot of countries, they didn't want charity. They wanted the ability to purchase the vaccines on their own to protect their own people. And we had way too many countries take advantage of the situation and their own situation and protect their people, which we get, which we understand, but at the expense of others. Some countries had, 8 to 10 vaccines per person that they purchased, while many countries, and 30% of the world still hasn't received a vaccine yet. So, we're still not there.
Can I add something to that?
Of course, please.
Yeah. So I was at a meeting that the WHO organized to try to expand the access to mRNA vaccines and to establish manufacturing hubs and so on. And the three things that they talked about were the fact that we need to diversify geographically manufacture. You have to have trained personnel, and you have to be able to hold on to them, don't lose them in a brain drain, and to ensure access to the raw materials. All of these are things that came out during this pandemic and will be an uphill task to solve.
Yeah, raw materials we took for granted, right?
Yeah.
Yeah, sure, we can get everything we need, but adjuvants sometimes are in short supply, many other things. So Maria, tell me one thing during the pandemic that WHO got right. Just one thing, because you know what the next question will be.
One thing WHO got right. Oh my gosh. I think, we take a lot of hits, rightfully so, because we have an accountability. We hold ourselves accountable for the work that we do for our member states. I think our ability to act fast and get some of this guidance materials out and to convene the world's expertise regularly, expand our partnerships, expand the different types of technical disciplines that we worked with during the pandemic. And because everybody went virtual, we actually were able to include many more people. Normally we have these guideline development group meetings in person. And so because everybody went virtual, we were able to link people right away. One of the things I'm really proud of in the beginning was I was the MERS focal point, and there was a clinical trial that was occurring in Riyadh looking at, it was the Miracle trial. And within the first couple of days, we put clinicians who had dealt with not just MERS, but also SARS, on the phone with clinicians in Wuhan and said, what are you doing, what are you seeing, and putting those groups together to offer that peer-to-peer learning. We shared the protocols from the Miracle trial with researchers, clinicians in Wuhan to see if that would work. That is the type of collaboration and trust that is built upon decades, and that worked across the entire spectrum. The people in this room, many of whom work on different virologic aspects in lab, came together immediately, and we published that PCR protocol with Charity University and Christian Drosten with help from many different groups. That started PCR production capacities where we were shipping PCR tests to Africa, at the end of January, early February. That's astonishing. And so there's a lot of things that went well, and there's a lot of things that went wrong, which I know is your next question.
Name one thing that went wrong, because you can learn from your mistakes, right?
We're constantly learning from our mistakes. One thing that went wrong, I think on the solidarity side, that was really hard. I think we focused much of the aspects of our response on the health sector, even though in the beginning we said this is all of government, all of society response. I think it was very difficult to ensure the political leadership that was needed right from the beginning. I think the mechanism by which we have to raise this alarm has its limitations. I think arguably the world woke up when the Director General described the situation as a pandemic in March, whereas it should have been a lot earlier. And I think that's something we really need to reflect on.
Okay, another one. It's quite clear that SARS in 2003 came from a live animal market, and there's tremendous evidence that SARS-CoV-2 also did. So many people are wondering if, it's clear that live animal markets are risk factors for zoonotic outbreaks, right? Is WHO going to make a statement at some point saying you shouldn't do this, or is that not something they would venture to do?
We actually have many statements out on this. We have, we work across our quadripartite with FAO, with WOHA, with UNEP now, on this, and looking specifically at wildlife trade, wildlife markets. I did my PhD in live animal markets in Cambodia, so I have a fondness, I don't know if you can say, for the research that goes on there, and the life market's place in communities, But I think much more needs to be done in this space. Certainly looking at how they are regulated, how they operate, whether they should operate or not. And I think what I was trying to talk about the other day is we really need to look at the incentives and disincentives around this. These are billion-dollar industries. And if we don't address this, we're going to be in a similar situation again.
The WHO could be in a leadership position and say, these are not a good idea and you should close them, right? It can't enforce it, but...
We can't enforce it, but we do have guidelines. We do have advice out on this.
Right.
specifically.
Now, I don't remember the year, but there was a committee convened by WHO that went to China to try and investigate origins. And it's not clear to me what happened to that committee. Maybe it's not clear to you either. It was supposed to reconvene.
It's pretty clear to me.
What happened? Is that going to go on?
You're talking about this pandemic. The SARS-CoV, yes. So there's been several missions to China. There was one early in January, which was our regional office and country office that went in primarily to figure out what was going on, to see if we could reduce the spread at the moment, understand the extent of infection. There was a mission I was on in February 2020 where we were looking at what was happening around the country. We touched upon the start of the pandemic, but at that time, it was just the country was on fire. And the world was starting to burn. And then there was a mission that took place in January, February 2021. And they produced a report which looked at, and some of the people on that mission are in this room, produced a report looking at the different ways in which the pandemic could begin, looking at the different hypotheses. And they worked under tremendous stress and a pretty tremendous situation. It was an international team and a team from China as well. And they produced a report which looked at the various ways and looked at the likelihoods. They also issued in that report a number of recommendations of studies that needed to be done, looking at everything from a zoonotic spillover event, the market, early cases, looking at serology, looking not just in China but elsewhere, looking at potential breach in biosafety, biosecurity. That report was published, and following that report, what we did at WHO, it became quite, let's say, political. And quite polarized in terms of looking at this. And what we were trying to do, WHO was trying to get those studies done. How could we ensure more collaborations were happening with researchers from China who have incredible capabilities to work with the international team, to work with international scientists, and we really didn't progress that very much. So WHO established a scientific advisory group to study the origins of novel pathogen SAGO, to take this on, because we weren't able to progress. We weren't able to send any more missions in. And the original idea was that we would have many missions following that mission. Maybe one mission looking specifically at animal markets and upstream sources, maybe some missions looking at breaches in biosafety, biosecurity, because the challenge is when you have hypotheses that are out there, if you don't have the information to completely take them off the table, they still persist. And so for us, that's why we keep saying that all hypotheses are on the table. It doesn't mean all hypotheses have equal weight. And so SAGO has been meeting. It's been working with, we've had lots of different researchers present to SAGO. They published a report in June 2022 saying more work needed to be done. And then there's been some recent studies that have looked at data from China CDC from January, February 2020. But very little has really progressed in terms of a lot more studies. I think there is much more data that's out there that needs to be analyzed and discussed and debated.
Well, it's a distraction, actually, that needs to be resolved, I think, because, over half of the U.S. believe this virus came from a laboratory, which is incredible, given... It is. We look to WHO to say, no, folks, this is how it worked. And so hopefully you can do that at some point.
I'm really hopeful we could do that at some point. There's reports that are coming from the U.S. that WHO doesn't have access to.
Yes.
So, nor the data that underlie those reports. So there's a lot of information that isn't being shared, and that's the challenge. So as scientists, we look at what we can say and what we can't say, and it's very difficult to prove a negative, as you all know.
Of course. That's science, right? That's how it
science,
works.
Yeah.
So you talk about the FBI and the DOE reports. We don't know what's in them either. They don't tell us. So I see you're in the same ballpark as we are. Let's talk a little bit about, let's continue with COVID, and let's talk about something you've written a lot about, vaccines. Many people are confused, right? Because we had one vaccine for a long time, then we moved to incorporating some Omicron components. And I want your thoughts on, is this going to be a frequently revised vaccine like influenza virus, or do we not know yet? What do you think?
Yeah, no, so I think we were all very hopeful at the beginning that we had a vaccine that was performing really well. The efficacy data from the clinical trials and the early use of the mRNA vaccines and other vaccine platforms against the original strain, against the Alpha variant, all the way through to the Delta variant were very, very good. And so we were hopeful that, but the WHO put together a committee that I chair called the Technical Advisory Group on COVID-19 vaccines. And we were tasked, and this was around the time that Delta emerged. So we were talking about the emergence of Delta and whether the vaccine strains needed to be updated. And the discussion, of course, was, do you follow what we do for influenza? And I'm involved as a WHO Collaborating Center Director with the vaccine composition updates for influenza that happen twice a year. Now, half the scientific community says, don't ask the flu people, they don't get it right. But on the other hand, influenza is the only vaccine that gets updated each year. So surely you should use at least part of the structure, learn from it, and adapt it for specific needs. So, of course, Omicron came through, and that is really a game changer in terms of antigenic change. So we have met regularly. The committee meets regularly. We have a subcommittee that advises us, virologists and immunologists that get together and provide more specific advice. The cadence of how often we're going to meet is probably twice a year. We had a meeting last week, and we're hoping that the recommendations of that get released later this week. And we've said that we will keep an eye on the evolution of the virus. It is very complicated because the virus continues to evolve and population immunity is very variable. We've got a lot of hybrid immunity from infection, from vaccination. It's different in different parts of the world. So, and the WHO, as Maria said, is making recommendations for the whole world, not the FDA's recommendation for the US or the EMA for Europe. So we're really looking at making a recommendation for the whole world. So why twice a year? Because I think we know that the vaccine-induced immunity does decline over time. And if you vaccinate large swaths of the population in the Northern Hemisphere, say in the fall of this year, you get a boost in immunity, and that boost in immunity will provide cross-reactivity and cross-protection, but it will wane. At least that's the data that we have so far, that it will wane. So as it wanes and the virus is evolving to escape immunity, the changes are in neutralizing antibody epitopes. So if you have the emergence of immune escape variants that come up around the time that population immunity is declining, that is a recipe for a surge. So the Technical Advisory Group on Virus Evolution keeps an eye on things, on the evolution of the virus, and we will take a look at least every 6 months at whether the vaccine strain needs to be updated or not. So by saying that we'll meet twice a year doesn't mean we'll be updating vaccines twice a year, but we will review the data every 6 months. And, seasonality, as Maria said, is not so clear. So certainly people's behavior changes in winter in temperate climates, but in the rest of the world, the Beta variant, the Omicron, the Delta emerged in warm countries in warm weather. So I think we do need to keep an eye until we learn more about the virus.
So this is part of your work as an influenza center, right? You collect thousands and thousands of specimens, and then you also look at antibody neutralization assays. So for flu, is it neutralization? That's the main metric for determining?
It is. We use a surrogate called hemagglutination inhibition, which is a surrogate for neutralization, but that is our workhorse.
Right.
And we use animal sera. So we're monitoring the antigenic change. So we have tons of sequence data, not nearly as much as with COVID-19, but we do get a lot of genetic sequence data, and we have a lot of antigenic characterization data that's done in ferrets. Now, what's going to happen with SARS-CoV-2, of course, we have this wealth of genetic sequence data. We have a real dearth of antigenic characterization data, so that needs to change. And because of hybrid immunity in the population, it's very hard now to rely on human sera. And so we're going to have to figure out is what's a good surrogate animal serum to use to characterize antigenic distance, because the point at which you would recommend an update to the vaccine is when there is genetic and antigenic change accompanied by evidence that the previous year's vaccine is not working, whether you get that information from animal models or you get it from performance of the vaccine in the public.
So for influenza, do you ever look at disease burden as part of that?
So we do. What we look for primarily is that when new variants emerge that we pick up either from sequence data or from antigenic characterization, we try to see whether they're causing outbreaks of disease in one or more country. So it isn't just one pocket of a variant emerging in one area that's not seen anywhere else. But if that same clade or subclade of virus that evades the antibody induced by the previous year's vaccine is actually spreading in different parts of the world, that's key.
So do you believe that neutralization is going to be the metric for SARS-CoV-2?
Yes, I think so for two reasons. One is that neutralizing antibody is clearly one of the correlates of protection. But it's equally clear that T-cell immunity probably plays a very important role in protecting from severe disease and death. But it's very hard to measure cellular immunity. And so neutralizing antibody is a very good surrogate that can be used as the basis.
Sounds like someone needs to make a really easy T-cell assay. I mean, just as easy as a neutralization assay, right?
Well, that would be nice.
Yeah, and we also need, I think, in terms of what we as a general public and caregivers want, is prevention of infection. And so we need to understand much more about mucosal immunity and have vaccines that prevent replication in the upper respiratory tract and spread.
That's tough for more than a few months, right? When antibody levels are high, and they never remain high for most.
Yeah, so I think that the difficulty with mucosal immunity, and this is from flu, from RSV, from all these respiratory viruses, is that it's difficult to elicit, it's difficult to quantify, and it's difficult to maintain. So there are three things that make mucosal immunity so challenging. But that, I think, is something that we should all be thinking about and some young people working on.
Right. So this is obviously in WHO's interest as well, because you have a committee that's looking at potentially changing vaccines and what kind of data you need for that, right?
That's right. And I think that's why it's so important that the work continues on SARS-CoV-2, despite all of the challenges that everybody is facing in terms of everything else circulating, plus the pressures that people are under, the reduced fiscal space. It's really important because the virus is still here. It's still causing disease. It's still causing quite an impact in some countries, and we expect further waves of infection. That is a certainty. What we are seeing is a reduced impact each time, not because the virus is changing in terms of its severity, but we're getting better at dealing with it, and population level immunity is so high. But as Kanta pointed out, it varies around the world in terms of the hybrid immunity that we're seeing, and immunity wanes.
All right, last thing I want to talk about, I don't want to stand between them and lunch, right? Which is, you both are interested in influenza H5N1. Would I be wrong in saying WHO is interested?
We're very interested, yes.
And Kanta, you've worked on it as well. So this is an influenza virus of birds. It's highly pathogenic. And so what's going on now that is particularly concerning about it?
So we've had H5N1 viruses around since 1997 that crossed into people in 97, and since then sporadically, hundreds of cases over the last 25 years. But what's changed is that these viruses have evolved in their natural hosts, in wild birds. And as they've evolved, the current clade, so now we're talking about a fourth order clade, this clade of H5N1 and X viruses are reassorting very easily. So they're acquiring different neuraminidase, which is just a marker for their promiscuity in reassorting with their other gene segments. So to me, the biggest concern is that these viruses are now spread around the world in wild birds. They are crossing over into mammals. Many of those infections, we think, are from the mammals eating dead birds or being exposed to dead infected birds, but there have also been some larger outbreaks. So I think, there's an argument in the field for the last at least 10 years that H5N1 viruses that emerged in 1997 and then re-emerged in 2004 would not cause a pandemic because by now they should have done so if they were going to. What we have now that worries me is that there are infections in mammals. And as these viruses cross into mammals, they may acquire the ability to infect, replicate well in mammalian cells, and transmit. So I think the bar is higher. So far, we haven't had a huge number of human infections, and the human infections that have occurred since this 2.3.4.4b subclade has emerged have been quite limited, and some of them have been mild or asymptomatic. A few of them have been severe. But I think the risk is much higher for emergence of a virus that could infect humans efficiently and spread. Hasn't happened yet, but we need to really watch.
So part of the problem is that there have been many more bird infections this year?
Many more bird infections. It's established now the virus has arrived on all continents except Australia and Antarctica. And in Australia, it's more, I think we're protected because the migration happens at certain times of the year. So I think we've bought ourselves a few months, but we're sitting ducks for the next migration.
Sitting ducks. That's good. That's good. So what mammals have been affected? Some minks, right?
Yeah, so it's, foxes and just a whole range of small animals in the wild. And I think one of the things that worries me is that, it's not clear who does the surveillance of those. So the assumption is that those mammals are infected by having eaten an infected bird, but we don't know, we don't have surveillance in the wild animals to know, much as Linda Safe was saying about SARS-CoV-2. Sure. So how do we know whether the virus gets established and transmits in wild animal populations? And there have been there's been outbreak in Peru in seals, and then of course there are the mink outbreaks as well. So these are, causes of concern. I think it raises it from where it was. Is it as high as, the next pandemic? No. But I think as these incursions into mammalian species are a concern.
Do you see any evidence for mammal-to-mammal transmission in the wild yet?
So it's very hard to tease it out in the wild. The seals and the mink outbreaks, it's very hard to show to know whether those were still point source. All the animals that were in that group could have been infected by a point source. We don't know yet.
Okay. So what does WHO have planned in case there's an H5 pandemic?
Well, there's an entire global influenza program, that's been established. There's an entire global lab network that's been in existence for more than 70 years. So surveillance is really important, but it's not just a human health point of view. So we're working with OIE, or now WOHA, the World Organization for Animal Health, with FAO and with UNEP on this, because it's truly a One Health issue. It's truly a animal-human interface in animals. And as Kanta has pointed out, we need better surveillance in wildlife. We need better surveillance in domestic animals, along the animal trade, at the animal-human interface. And that's something that regularly needs to happen to look at that risk. But these pathogens that cause outbreaks, they're zoonotic. 70 to 80% of them, spill over from animals to humans. And even what we see with SARS-CoV-2 spills back into animals. We have this reverse zoonosis. So the risk is there. And the more opportunities these viruses have to jump between species, the more opportunities they have to change and reassort and, acquire characteristics that could make them that next, to transmit efficiently. So it's important for us as an organization to be ready across the entire spectrum, whether it's to get the vaccine production ready to change, to develop vaccines for this, and there are vaccines that have been in development for H5 for years, but also across our clinical management, looking at the antivirals, what antivirals exist, where are we in terms of access, in terms of production, what does IPC capacities look like, mask production, all of that needs to be reassessed constantly, because flu is a certainty. We have seasonal flu every year. There will be a pandemic of influenza. When? We don't know, but that is something that is planned for. And the same thing across other pathogens. We may have an arbovirus type pandemic, and climate change and the way in which we live on this planet is changing the dynamics of how these pathogens spill over, and it's increasing in frequency.
Can I just add one more thing?
Yeah, of course.
You know, from the virologist standpoint, it's also the reassortment, because there's reassortment of the viruses after they arrived in North America, and so they're picking up Eurasian genes and North American internal protein genes, and we, you know, so in addition to knowing that they're cases, we actually need to know what the gene constellation is and what that gene, which gene constellation will suddenly increase the risk.
So this underscores how important surveillance is for influenza, and you probably know there's been some pushback on surveillance of coronaviruses in bats in certain parts of the U.S., and I think it's laughable in light of what we do for influenza and what we need to do, right?
Exactly.
All right, I have one question for you both, and then you're done. Kanta, if you hadn't been a scientist, what would you have done?
Oh, I need time to think about that. I just, you know, maybe a physician? Yeah, that would be an easy one.
How about you?
I don't know. I can't imagine myself in a different field. I mean, I really just love public health in this aspect of it. I danced a lot when I was in high school, and I loved it, and I taught dance. I was there, but no, I can't really think of anything else.
All right, that is TWiV 1009. You can find show notes at microbe.tv/TWiV. Questions, comments, TWiV at microbe.tv. If you enjoy our work, we are a nonprofit production company. We depend on your donations, which are U.S. federal tax deductible. You can go to microbe.tv/contribute. I want to thank the meeting organizers, Volker Thiel, Isabella Eckerly, and Ronald Dykman for having us, TWiV, at this meeting. Really appreciate it. I understand this episode was supported by the UK International Coronavirus Network, so thank you very much. My guest today, Maria von Kerkhove at WHO in Geneva. Thank you for chatting.
Thank you so much for having me.
And Kanta Subbarao is at the Doherty Institute in Melbourne. Thank you very much.
Thank you.
I'm Vincent Racaniello. You can find me at virology.ws. I'd like to thank the American Society for Virology, the American Society for Microbiology for their support of TWiV, Ronald Jenkins for the music, and Jolene for the timestamps. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.